the role of local anesthesia or regional block techniques, there are now coming out data that show that local anesthetics used by local infiltration and usually done by the surgeon, as well as paravertebral and erector spinae regional blocks, are becoming increasingly popular. It has been shown by a South American research group that even a transverse plane thoracic block applied on both sides of the sternum at 3 levels will completely eliminate the need for post-operative opioid use. So to my opinion, in modern anesthesia, we not rely anymore on single post-operative pain management by opioids, maybe combined with acetaminophen. However, the combination, so the multimodal approach, seems more likely to result in less post-operative pain and a faster recovery. The data are growing, but are not yet of a level of evidence that it can be recommended.
Yes, indeed. Thank you. In fact, you're completely right. Actually, we had the annual meeting of CCAS last 2 weeks ago, and one of the topics was about local regional anesthesia and analgesia in congenital cardiac surgery, and there was a pro and con discussion, and Dr. Alexander Mitnack took the con discussion, and one of his major concerns was that there are very few well randomized studies to prove that it's really safe, because actually all the studies that have been performed are not powered for safety. So this is one of the major concerns that should probably be taken into consideration for future work. I don't know if Dr. Nicholson has any comments on that for enhanced recovery, the use of local regional anesthesia and analgesia.
We do not use it, but there, was just mentioned, there are a huge number of places with increasing frequency, but I think that we really need to look at this with critical questions so that we can get the answers in the requisite number of patients. Yeah.
Okay. So another question is, Dr. Nicholson, for you is, you spoke about opioid sparing strategies. You know that nowadays opioid-free anesthesia is very much used in many countries, actually in Europe, in adults mostly. Do you mean by opioid-sparing strategy opioid-free anesthesia, or just reducing the doses? What is your experience about that?
Well, I think it means different things to different people, like most of these concepts that we're talking about. So I think it's important to define it. I think opioid sparing means less than you would give previously. And opioid free is an anesthetic that does not consist of an opioid.
Yeah, but if you then use less opioids, do you replace them with something else? I guess with Dex or with other things like ketamine or.
I think that, for instance, in our practice, we use less opioid or no opioid, use ketamine. Volatile anesthetic is the mainstay for the intraoperative piece, and then towards the end of the case, give intravenous acetaminophen, followed by intravenous dexmedetomidine. We normally give a mic per kilo just after chest closure so that one separates the hemodynamic consequences of chest closure from the dex administration. And then we usually start a continuous infusion of ketamine and dex in the intensive care unit after the patient's been already extubated, either in the OR or in the ICU on arrival. I think that it's just a question of people's comfort level of taking a freshly extubated patient and traveling from the operating room to the ICU. So many people choose to just delay the extubation till they arrive in the ICU, and then that enables the OR to turn the room over and facilitate the next patient going into the room.
Yes, right. I really liked this enhanced program that you mentioned. My main concern, actually, from my personal side, is do we need an extra personnel to do that? Because I think, just by an anesthesiologist alone, maybe is not able to change everything in such a busy in a busy center. If you're performing cardiac anesthesia, and if you want to implement this enhanced recovery program, then you have to go and see your surgeons, your cardiologists, the intensivists, the nurses. It's to implement such a thing is not that easy, I guess. Do we need to have an extra personnel to do that, or?
Well, I've never done it. I think it's a very laudable goal, because I think that if you look at, for instance, fast track early extubation, that very frequently you may extubate the patient earlier, but does that translate into anything meaningful after the extubation? Are the patients discharged from the ICU or the postoperative step down unit earlier? Are they able to get enteral feeds earlier, non-pharmacologic comfort measures earlier, lines out earlier? So I think that's the value of an ERAS program, but an ERAS program is very labor intensive, and I think it has to be a decision by an entire perioperative cardiac team that they want to take this on. And then I think you have to define what is necessary to do it, either additional personnel or personnel who have dedicated time, if such exists in their current arrangements, to champion such an effort, which is a lot of work.
Yeah, right. Yes, thank you. We have a question for Professor Habra, and the question is, if we cannot perform recruitment maneuver due to hemodynamic instability, may we use a 5 centimeter water PEEP as a safe and useful value?
Well, if you apply only PEEP, it will not help. It will not help at all. There have been studies where comparing applying a CPAP or a PEEP without recruitment and recruitment with PEEP, and clearly you will not reopen the closed alveoli. What you can do, however, if they are unstable, but that will depend also on how unstable he is and whether you can optimize the hemodynamics either by fluid or by vasopressors like noradrenaline, for instance, to increase the venoconstriction and increase the venous return, and then help increasing incrementally and very softly to recruit, or position the patient differently on one side or another to open the airway, the closed alveoli, and then 5 centimeters of water might be enough. But I mean, there's no magic number, you know. You have to actually see what's the reason for this airway closure, and then the other thing is why he's hemodynamically unstable, that potentially you may have to optimize the hemodynamics before going to the recruitment.
Yes, thank you. Now, Professor Harp, you show that positive pressure ventilation has an important effect on right ventricle. And as you know, the tetralogy of Fallot physiology is very complex. These kids can sometimes have a very dysfunctional right ventricle from a diastolic point of view, and very often coming off bypass, they need a lot of fluids. So on one hand, you would like to extubate them to take them off the respirator, but on the other hand, you're giving fluids, and you know that in the upcoming hours they're going to be to take some edema. So how to deal with that? Because these are the kids that we struggle with a couple hours later in the intensive care unit. What is the best strategy to ventilate these kids?
Yeah, I agree with you. I mean, the tetralogy of Fallot, and I showed you actually the graph, they do react differently than those who have initially a high pulmonary blood flow. However, I'm very, for the right ventricle, and particularly tetralogy of Fallot, using a combination of norepinephrine and the balance with the fluid, and milrinone, you know, like for the diastolic function. You know, I think this is the way I manage these patients, right? This combination of these two, because that's the best to optimize the right ventricle. Norepinephrine also will will allow a better coronary perfusion for the right ventricle, and also will allow a venoconstriction and better venous return. So somehow, this is the way I manage these kids, to be honest.
Yes.
But again, the thing about them, tetralogy of Fallot, unless you have a really great inflammatory response during cardiopulmonary bypass, what we tend to do also is to keep partial pressure of oxygen very low to avoid any reactive oxidative stress that will again deteriorate also the lung function. Remember, the lungs are usually normal. Meaning the compliance. Well, of course, when you reestablish the circulation, you have also ischemia reperfusion. But very often these kids need a very lower tidal volume than the others, right? So I mean, you have to balance between this ventilation and optimization of the hemodynamics, definitely.
Yes, thank you. Next question would be for Professor Rex, and that's an interesting question. The question is, I don't have dexmedetomidine available. Can I substitute it with clonidine for early extubation? It is all of course, dex is you're maybe muted. Dexmedetomidine is not very cheap neither.
Yeah, at least in Europe, it's now no longer patent protected. So the generic formulations will come on the market, or are already on the market. But in fact, it's more expensive than clonidine. And interestingly, there are, in my opinion, I haven't found them yet, but there are no head-to-head comparisons between clonidine and dexmedetomidine. In fact, dexmedetomidine is the little brother of clonidine. It's a little bit smarter because it has much more affinity to the alpha-2 receptors and to the alpha-1 receptors. And the big advantage is that the half-life of dexmedetomidine is around 90 minutes, whereas in clonidine you have durations of effects of 12 to 24 hours. But if you don't have dexmedetomidine, and then clonidine is certainly a viable option or alternative. But be very careful to find the right dose, because when you then have hemodynamic side effects, even if they are of modest magnitude, you will have these side effects for the next 12 to 24 hours. But basically, some of these meta-analyses have shown the same effects for clonidine as for dexmedetomidine. For example, opioid sparing effects were as large as for dexmedetomidine when clonidine was used, at least in adults.
Yeah, but I have the impression that the clonidine gives more arterial hypertension compared to dex. Is that my impression, or maybe the others can comment on that? Dr. Nicholson, do you have any experience with that? You're still muted.
I have no experience with clonidine. Dex is readily available, and but I think that my major concern about clonidine would be the long-term effect.
Mm-hmm. Yeah. Okay. Another question for Dr. Rex was, any experience to use DEX during the short procedures like CT, MRI, cath lab, or anything?
Yes, for example, at our institution, we now use dexmedetomidine for sedation in the MRI, so procedural sedation in its pure sense. And this also works fantastically. So it's a very useful drug for these procedural sedations.
Mm-hmm. Okay. Dr. van der Maten, there's one question regarding immediate untable extubation, and that is, would you recommend any interventions to be taken to avoid accidental decannulation of invasive monitoring lines by the small kids? Do you have any recommendations? That's, of course, a difficult, a very long question. It's not that...
Yes. Yeah, I see the point. Usually, children remain as many people who awake or arouse from anesthesia remain in a sometimes subconscious state of mind. And the idea actually is, and we see that in the adult population, especially in the geriatric population, that the use of benzodiazepines is unpredictable in the way that patients wake up after surgery. Actually, it's a question that I would like to return to the panel, is if we approve of, or actually are in favor of, the use of benzodiazepines, especially in the neonates, concerning the possibility of on-table extubation and fast-track recovery. Is there actually still a place for benzodiazepines in pediatric cardiac anesthesia? Stefan, maybe?
Yeah, that's a good question.
We have skipped our pre-medication already several years ago. So we allow the parents to accompany their children into the OR, and yeah, you know, with the sedative pre-medication, it's always a mess because it's always given too late or too early. So if you are very honest and you do a quality control of your pre-medication, I think you can be happy if in 30% of the children it has been given at the exact time point. So we skipped it, and actually with the parents in the room, we have usually very good induction conditions. So I think also that the benzodiazepines, I still do not know whether I have to believe in anesthetic neurotoxicity or not, but I think the data from adults are very clear that benzodiazepines interfere with the transmitter systems in a very significant manner. And why should I take these disadvantages? Why should I take these disadvantages in the children if I have only little benefit from the pre-medication effects of benzodiazepines?
Okay.
And I think also, I mean, we have skipped it also in the adults. If you are really interested in fast track, then I think there's no place anymore for benzodiazepines, in my opinion.
If I may react, Mona, from that perspective, you have the privilege that you use Dexmed, and in my hospital we don't. So there should be an alternative, and the only alternative is propofol then.
Yeah. Yes, yes. Dr. Nicholson would like to comment. Yes, please.
We very frequently use pentobarbital preoperatively but obviously you need to have sufficient time, oral pentobarbital. And that is also another alternative for use postoperatively when dexmedetomidine is either not available or a patient has an idiosyncratic reaction previously to dexmedetomidine.
Yes, okay. Yeah, we bring the parents inside the OR as is done in the hospital where Dr. X works. So that's another option. But of course, that's only in the preoperative period. Postoperatively, it does not probably have any effects. Maybe we can take one last question before ending up the session. And that question I would like to ask Dr. Nicholson. That's, does the preoperative anti-failure therapy in the form of digoxin, Lasix, beta blockers for large left-to-right shunts, should it be considered as a contraindication for untable extubation?
I don't think those things in and of themselves. My view is that any patient who comes to the operating room with a natural airway should be considered as a candidate for immediate or early extubation unless intraoperatively something changes such that they no longer are a candidate. But I don't think the presence of them taking those medications preoperatively or that physiology, if they come to the OR with a natural airway, should preclude them from being considered.
Okay, thank you very much. So if there are still other questions, well, they can be answered, of course, by on the website. And I think that now we can close this session. And I think that we have come to the end of this webinar. And what I would like to conclude is that from the lectures, I see that in 2021, early extubation and fast-track postoperative care should probably be part of the program in each institution where congenital cardiac surgery is performed. And to do that, of course, we need a sustained, enhanced recovery program, as nicely shown by Dr. Nicholson. And this program should be implemented by team members who are experts in congenital cardiac surgery and heart surgery, and who are, of course, aware of the medical consequences of what is this fast-track anesthesia. And of course, it takes time. It's not that easy, but if we want to change things, we have to start somewhere. And I am really convinced that each hospital where congenital cardiac surgery is performed, this enhanced recovery program should be implemented. So I would like by this to thank very much the speakers for their excellent presentations. I really enjoyed this session, and I would like to thank them for their time, because that's not easy to do such a webinars on an evening. I would also like to thank the organizers, AIM and the Multi-Learning Center, and of course I would like to thank Dr. Mohammed Eltahan, who is the chair of the Education Committee within EACTAIC. Without him, this webinar would have never been be possible. So really, thanks a lot, Dr. Eltahan, and of course the sponsor, our sponsor, which was Livanova, and all of you, the participants, for being with us and to participate, and for your interesting questions that will be answered later on, of course, on the website. So I think that maybe Professor Eltahan would like to give a word, and thank you again for being here with us. Professor Eltahan would probably like to give some words before that the session will completely close. Thank you again. Bye-bye.
Thanks so much, Mona. Ladies and gentlemen, dear colleagues, on behalf of Fabio Garashino, I am delighted to close this session. He apologized he cannot join tonight. He has an evolving situation at his hospital because of the surge of pandemic. First of all, I want to thank Professor Mona Momeni, the chair of Pediatric and Congenital Subcommittee in EACTA IC, for her efforts to organize this webinar. Special thanks to all members of Pediatric Subcommittee, as well, particularly Professor Joost van de Maat, for his efforts to organize this webinar. Also, I would like, on your behalf, to thank all talented and renowned speakers for this excellent talks. I actually enjoyed them so much, and I hope you have enjoyed this evening as well. Special thanks to the sponsor, Livanova, for supporting of this webinar with an unrestricted educational grant. And as you know, this webinar is accredited by the UEMS to provide 2 credit points. And here I'm delighted to advertise about the upcoming webinar on May 3rd. You need to mark your calendar. It will be provided from Nordex and on the perioperative blood management during cardiac surgery. And special thanks to all technical support received from Multi-Learning and AM for the great efforts during the preparatory steps and for conduction of this webinar. And thank you very much for everyone. We appreciate to being here, and have a lovely evening. Thank you. Bye-bye.